We're starting back with the third issue to be raised, and that is cost-benefit analysis associated with the inclusion of arts programs and interventions in healthcare delivery for older adults. And I'm going to moderate. We happen to have this very interesting topic for the time when everybody is the most alert and awake and engaged. So we do have some some terrific speakers for this afternoon's session. And one of them is my dear friend Emmett Keeler, and fellow Californian, who is a senior mathematician at Rand and professor at UCLA in the Pardee School, Rand Graduate School. He has done a lot with cost effectiveness dating back from the health insurance experiment and onward. And he's going to kind of try to put everything in perspective in terms of what we've heard this morning and some other studies with respect to cost effective analysis. Emmett?
Okay, thanks. Not sure how to move the slides, but...
You want me to do it?
Yeah, could you do it?
Maybe.
Okay, and then you have to hit the little slideshow icon. There we go, good. Okay, so I saw a lot of fascinating things this morning, and they all relate to interesting and fulfilling things that you get people to do, and then there's some benefits to them. But you know, the United States has the most expensive healthcare system in the world, and so whenever someone suggests let's do something else, we always have to say, well, you know, it sounds like a good idea, but what's it going to cost? And indeed, cost-benefit, are the benefits going to be bigger than the costs? Well, cost-benefit analysis and cost-effectiveness analysis are standard ways of evaluating health programs. And if you want to say that you're doing health programs, then you have to be subjected to this thing. In the next 30 minutes, I'm going to explain just some basic ideas. And I'm going to hit some of the more controversial ones harder. And, you know, there's a textbook that you can refer to for some of the things. But I just want you to get a feel for what people do in this. I'm going to bring up some specific issues for the arts and for geriatrics. And then Julene Johnson was nice enough to send me a paper by Cohen, and I'm going to do a practice analysis on that paper. So I'm going to do a cost-benefit analysis of that paper. That's the last 5 minutes of my talk. Okay, next slide.
So this works. Want to use it?
Yeah, sure.
Yeah.
This button here, and this is back. Okay, so cost-benefit analysis, it's a systematic listing of all the anticipated costs and effects of a spending decision. And all effects are given a dollar value. And in public decisions, which most of these are going to be, all of society counts. So sometimes people will say, I got to make a business case for something, company will come to you. And basically what they're saying is, my company wants to make money on this. But that's not what goes on in public cost-benefit analysis. In public analysis, all of society counts, not just the business. And in theory, by economic theory, you don't want to do things unless the benefits are bigger than the costs. So that's kind of a bottom line on any program. If the benefits aren't bigger than the costs, then it's not a good idea. Maximizing net benefits takes you to economic efficiency, but there's many more factors that go into making a decision. So that's just one of the inputs into the process. Okay, so let's suppose we're trying to evaluate an arts program for older people, like this one by Cohen that was sent to me. You have to pick measurable objectives. So you have to decide when you're starting, what is it that I'm trying to do? And you have to figure out some way of measuring it to see if you have succeeded in that. And Cohen, in his thing, he picked health benefits that were measured. Some of these benefits, I mean, what's a little tricky is that some of these benefits are tangible and others are intangible. So, for example, EPA does a lot of analysis of whether the air should be cleaner or not. Some of the benefits is it's just nice to smell and see cleaner air. But that's not quite the same thing as, you know, reduced number of cases of asthma or something like that. So in addition to these tangible benefits, there are intangible benefits. And of course, in the arts program, there's a lot of intangible benefits. It's people feeling better, people feeling fulfilled, and so forth. Hard to put a dollar value on those things. So the second thing you have to do is you have to test if a program works to improve the objectives. And ideally, with a design that shows that the gains that you see in the participants are due to the program. So Cohen's design was pretty good. It was before and after with a control group. And that's a pretty strong design. So you can have some confidence that what you're looking at is indeed due to the program. The third thing, this is where the cost analysis comes in. So you've got a program that works. You have to see, is this program worthwhile compared to other ways we could use the money? And that's where the cost analysis comes in. So, you know, there's a million people, not just the people in this room, but people in other rooms that do other things, all want money to do something good, you know, and you just have to say, is the thing you do worthwhile? Okay, there's a number of cost analyses that you might possibly do. And the one that you always start with is a table of the costs and effects for each of the options under consideration. So here's an example of a table. And on the columns, you put all the different outcomes that you're interested in. So here we have direct costs, indirect costs. If it's a health program, maybe there'll be something called medical care offsets. That is keeping people out of the hospital, let's say, or something like that. So it'll be a downstream benefit. And then you also have the effects. So an effect might be better health. In the case of arts, it might be the inherent value of the activity. And on the rows, you have the various options under consideration. So A might be some new program that you're trying to implement. B might be the status quo. And you're going to fill in all the entries of these tables, and you look at them. Sometimes you may, if you're a certain agency, you may have a whole bunch of programs you're deciding between. So there'll be rows A, B, C, D, E, F, and so forth. And you fill in all the entries. It's not so easy. That's what researchers do, is fill in these entries. And where did that come from? It might come from your own data. We've seen some examples of that. It might come from literature reviews. We've seen some examples of that. Or, you know, worst case, expert opinion, where experts might be real experts, or super worst case, it's your own opinion, and you put it in the cell. But, you know, if you're going to really judge a program, you've got to fill in all the cells. You've got to make a guess about what everything's going to happen. Okay, so let's go back to the other kinds of analysis. One kind of analysis that sometimes people try and make you do is a cost-only analysis. And in a cost-only analysis, the research question is, does this program save money? And so, you know, a lot of this is, sometimes people say this is the business case, so-called business case for this program. It's not a very good analysis because, you know, it doesn't include things that you're interested in, like the effects. So, you know, basically, you know, you have to ask, what does the medical care system do? For example, this is a rival way of improving health. Basically, you spend money and you buy health with it. So it's not like you spend money and that saves you money. That's not the way it works. There may be some cost offsets, but basically you spend money and you buy health. That's what the medical care system is all about. So many worthwhile programs do not save money. What they do is they generate something that we want. Okay, so we'll skip cost-only analysis, not a very good idea. The two real contenders are cost-effectiveness analysis and cost-benefit analysis. And what happens with cost-effectiveness analysis is you sum up all the costs and you look at one major aggregate effect of, generally it's some kind of combined measure of health. With cost-benefit analysis, everything is put in dollar terms. So when you get down to the health or whatever it is, you put a dollar value on that health and you see if the dollar value is bigger than the costs of the program. Okay, so as a researcher, sometimes you sounds like nobody's got to this stage yet, but when you get to this stage, you'll have to decide, do I want to do a cost effectiveness analysis or a cost benefit analysis? And it depends somewhat on the purpose of what you're doing. What cost effectiveness analysis is useful for is you can maximize the health effect within a given budget. So, and it turns out that this cost effectiveness analysis is fairly standard for medical treatments. Cost benefit analysis answers a different question. It says, is the program worthwhile? The program, according to economic theory, is worthwhile if the benefits are bigger than the costs. And you need cost-benefit analysis if there's a lot more going on than besides health. So, for example, in many EPA analyses, for example, you have a whole bunch of things. Health is one thing, but you also have, are the fish swimming in the river? Is the river nice to look at? Is the air clean? All these other things. And health is perhaps incidental to that. If health is just one of many factors, you have to figure out some way of combining health with those other factors. The way it's typically done in the government is by putting a dollar value on everything. And for most so-called regulatory impact analyses, they're all done with cost-benefit analysis. So there's big shops in EPA and the National Highway Safety Division and so forth that do these cost-benefit analyses. Okay, so here are the steps of a CBA. This comes out of a textbook by Boardman that I use in a class that I teach. And these are all pretty obvious. If you don't know exactly what you're doing, if you don't specify it exactly, then you don't know how much it costs and whatever. And you have to decide early on which and whose benefits, costs, and impacts to count. So you have to decide who's the thing. So I guess in dementia, you'd have to say, am I just interested in the demented people, or am I interested in their caregivers, or am I interested in somebody else? You have to decide. You have to say, who is this analysis about? What impacts are we going to count? So then you either take data out of your thing, or you predict costs and impacts, and you make out that table that I showed you. And then for a cost-benefit analysis, you monetize them. And I'll show you later how you monetize them. I'm not going to talk much about discounting. Many of these interventions, like the Cohen one, is just a one-year intervention. So we don't have to worry so much. Discounting relates to distant things that happen compared to current things we have. I'm not going to talk about that. You calculate the net benefit, which is the benefits minus the costs. And in theory, you choose the program with the maximum net benefit. And when you actually write these papers, towards the end of the paper, there'll be something called a sensitivity analysis. And why you do that is because as you do your analysis, you'll be making a lot of assumptions. Some of them are pretty good and some of them are shaky. And you want to know, what's the impact of changing these assumptions on the bottom line? Does it always look the same or is it different? The sensitivity analysis tells you that. Okay, so now I'm going more into the details of how you do it. First, we're going to say how you measure the cost. It's pretty easy, I think, for these interventions. You guys could probably set up some way of measuring the cost fairly easily. Basically, you make a list of everything that you do. You collect the time that it takes to do it. You collect the qualifications of the people who are doing it, figure out what their average wage rate is, and that gives you the labor costs. That happens both with the training, getting the program rolling, the setup costs, and then also the continuing operation and maintenance costs. And you'll have to decide how long the time span is that you're evaluating. And then maybe there'll be downstream cost offsets. So for example, in this Cohen study, there were slightly improved health effects, maybe a little bit of cognition effects. Maybe that'll impact whether someone goes into a nursing home 10 years from now. Well, you could have a model of that, but that's very speculative compared to the actual things that happen in this first year. And so it depends on the field how speculative it is, but I would suggest probably at this point, forget about that. Just keep it more up to date. So you collect the units of labor, the supplies, the overhead, and so forth. The costs are typically the sum of the units times the price. So the price would be the wage rate or what you pay for equipment or whatever. And that's given by the market for most items, but some items not so much. So a big issue in this field is what the cost of family caregiving is. So I think if you talk to a lot of people, they would say, and I don't have that much experience with severely demented people, but I'd kind of like to do something for my parents, but I want to buy out of 24/7 care or whatever. So I'd kind of like to do something that really isn't any cost at all. That's something that's part of being a family. But to the extent that they would really rather have someone else do it, you'd have to say, well, let's cost that caregiving by what you'd have to pay somebody to do it. Okay, so it's an issue about, very high-priced people might take care of their parents. But even so, you don't want to say that that care costs $1,000 an hour or whatever they bill their clients. Another question that comes up is patient time. So in many kinds of medical care, the patient has to invest quite a bit in their own care. And so the issue is, what is that time that they're investing? And is that time a negative for them, or is it a positive? And I think with the arts, it's not so much a negative, it's actually a positive. So to the extent that the treatment itself is fun, that's a benefit. That's not a cost. If it was something, I think some exercise programs where people really wouldn't want to do it, then it's a cost, the cost of that thing. So you just have to ask them. Okay, so, all right, now I'm done with costs. I'm going to go on to the benefits. The benefits, there's a whole bunch of health benefits. People have commented on this already, all the different dimensions of what it is that you measure. So typically for, if we were doing breast cancer or something like that, the primary benefit would be extending the life of the women that have it. But particularly when you get to older people, a lot of it is not so much what the quantity of life is, but more what the quality of that life is. And the quality of that life comes from things like functioning, feeling healthy or fit, being comfortable, feeling useful, having a good social life, things like that. And they're all kind of more or less health. And people draw the lines in different places. But for the cost effectiveness analysis, we'd like to have a unified measure of health that we could just call health and say we want to spend our dollars to maximize health. And it turns out there is a standard. There's something called quality adjusted life years. And that is the standard way that economists in this field aggregate morbidity, that's the life years part of it, with quality of life, that's the quality adjustment. So it's kind of a funny concept, but I'm going to show you how it's done. Okay, so QALYs, that's the nickname for quality adjusted life years. So this is an example. This might come out of a computer model of blood pressure treatment. And in the computer model, there'd be thousands of people that would have different life paths with and without treatment. But what's happening in this life path? Well, on the horizontal or x-axis, we have the years following treatment, how long this particular person lived in the computer. And so they live 20 more years. Unfortunately for them, they have a stroke after 10 years. So we'll get into what happens to them then. On the y-axis, we have a scale that measures the quality of their health. And that scale, you get a value of 1. If you're in good health, you get a value of 0 if you're dead. And intermediate values of health, like after a stroke, get some intermediate number. So here you see the person lives first in good health for 10 years. That counts 10 quality adjusted years because there's no adjustment because they're in good health. Then they have the stroke, and somewhere someone has figured out, and I'll explain in a minute how we do that life after a stroke is 70% as good as life before the stroke. So the 10 years that they live after the stroke only count for 7 years, 7 quality adjusted years. The 10 years are adjusted down by multiplying by 70%. So in total, this particular person lives 17 quality adjusted life years. Well, whenever I present this, what the natural question is, where does the 70% come from? How in the world can you do that? Well, it's done by surveys. And I'll give you one example here. This is the so-called time trade-off method of eliciting this number, 70%. So you tell people, suppose you might live 20 more years, and then you describe some state. And this, I'm not an expert on stroke, but the state that you might describe is your speech is slurred, you have trouble walking, I don't know what all the different manifestations are. And you say, how many years would you give up if, instead of living in this reduced state of health, you could live in good health? So if someone says, for me, 14 years of good health is like 20 years in this bad health, then the factor is 14 divided by 20, or 70%. So you ask this of a whole bunch of people, see what they say, that's where the number 70% comes from. And you know, there's websites. You can look up pretty much anything that'll have 10 studies that have surveyed this, and you can take the median. I mean, there's an unbelievable amount of information on how people have rated impaired states of health that you could use in your studies. Maybe it won't come up. Not so much on cognitive impairment, but certainly for any kind of physical problems. Okay, so the other kind of sticking issue in cost-benefit analysis is how do you put a dollar value on health? So that's another interesting question. So what is an extra year of life worth? That's what we're trying to get to. Well, according to economic theory, the value of anything is what people are willing to pay for it. Okay, so the value of health is what people are willing to pay for it. And there's a huge literature on this, but there are two main ways that people have tried to get those dollar values. One is from what's called implicit choices, and the other's from surveys. The implicit choice refers to hazard premiums for workers. So what happens is if you observe people who have dangerous jobs, they have been paid extra to take those jobs. They've been paid extra for that risk. It's kind of hard to see because typically they're young, crazy guys that are in those jobs. You know, like I've done this calculation for example, enrolling in the Army when there's an active war going on. But you adjust for that. You adjust for that and you try and get what is the pure hazard premium that people are being paid to take extra risks in their jobs. The other way is you do surveys and you ask people, what would you pay for a better surgeon? So imagine that with a normal surgeon, you have 2 chances in 1,000 of dying. With a better surgeon, you have 1 chance in 1,000 of dying. What would you pay for that better surgeon? So if you look at the literature, it turns out for a 1 in 1,000 reduction in the chance of dying, people are willing to pay $1,000 to $10,000. So this is middle class people that are surveyed. And you can do some calculations, and that'll tell you, as it turns out, that the value of an additional year of life is between $50,000 and $250,000. And those are the kinds of numbers that you stick into these analyses of what the extra health is worth. So there's some special issues for arts in the elderly. Everybody's talked about this already. Doing arts may be valued by participants for more than their health gains. They're fun to do. So how can you get that? You do willingness to pay. So, you know, what are people typically willing to pay for a nice hour of stimulating fun? That's one issue. Another issue is that with older people, the trade-off between length of life and quality of life may be a little different than it is for younger people. So typically, I know from talking to David, the geriatricians really focus on making the quality of their patients' lives better more than they do extending their lives. So those are just 2 special issues that will come in if you do these analyses. So now I'm going to get to my example. This is the choral singing program, and I've rounded a lot of numbers to make the calculations easier, and I also reanalyzed the data. But so what? Anyway, so basically 80 people were assigned to choral singing, and they had a control group of 80 other people. They did a before and after analysis and looked at what happened to certain measures of health. And these were sessions. These choral sessions were run by professionals. So, you know, pretty classy thing all the way around. And the results, the health results were better mood, better self-reported, that should be reported overall health. And it actually, I was doing it on the plane again, it's 0.2 standard deviations, but it won't affect my analysis. They had too fewer doctor visits over the year. They had a little bit less meds, they had a little bit less falls, and they did more weekly activity. So at the end of the year, you know, a lot of minor positive things that happened. And they didn't really report anything about costs. So I sang in a choir myself, and it's about the same size, about 80 people, and I know what we spend, and that's what I'm going to assume they spend. Now, if you were doing it yourself, you'd want to do better than this. But anyway, I'm saying $50,000. That's the cost of having these professionals do 30 sessions. They did some other stuff too. Now, let's talk about the medical cost offsets. The big one is the 2 doctor's visits, a few other minor things. I'm going to assume that's $250 per participant. So These are the 80 people in the choir times the $250 lower medical expenses. That's a saving of $20,000. So the net costs are the $50,000 that you paid the professionals minus the $20,000 that you saved on medical costs, are $30,000. So the net costs of this choral program are $30,000. Okay, so what are the benefits? I calculate them to be $800 per person, and here's how I got that. I assumed that the 0.2 standard deviations of improved self-reported health were the same thing as 1% difference on this scale of health, where 0 is dead and 1 is perfect health. Now, we could do better than that if I had more than 15 minutes to work on this problem, but that's what we're doing. We're saying it's 0.01 QALYs. And the program lasted for a year, so the 0.01 becomes 0.01 quality adjusted years. So that's the health benefit. If a QALY is worth $50,000, that health benefit is worth $500. So there's $500 worth of better health. In addition, I assumed that the fun of singing was worth $10 a session. So they had 30 sessions, so that's another $300. So they had $500 of health, $300 of fun. That adds up to $800 of benefit per person. There's 80 people, that's $64,000 of benefit from this program. So the benefits, $64,000, are bigger than the net costs, $30,000. So program, you might do the program again. I want to emphasize, I didn't make this point earlier and I probably should have. We're not interested in seeing whether the research is worthwhile. We're interested in seeing whether the program is worthwhile. So if there's any research costs, you don't consider them in the cost-benefit analysis. You're not trying to tell other researchers what to do. You're trying to tell other community people what to do. Okay, so anyway, the benefits are bigger than the net cost, but the program is not cost-saving. The program costs $30,000. So we spent $30,000, we get $64,000 of benefit. That's the end of the analysis. So, it's all rough. On purpose, I've shown you that there's a lot of, kind of warts in this. You can do it better. But that's cost-benefit analysis, and that's my talk.
I'm certain that some people may have some questions for Emmett, but we'll catch those at the end of the session. Our next speaker will be Melissa Castora-Binkley, who is a doctoral student at the School of Aging Studies at the University of South Florida, and she's going to lead off here, right?
Yes.
Okay. Actually, we have to get the next set of slides up.
Oh, this is it.
This is you. Okay. All right, there you go.
I'm actually a doctoral candidate now. I just passed my exams, so. Okay, well, I'm sure all of you that are familiar with this research are wondering how the heck we're going to talk about cost and cost effectiveness when there's really no reporting on costs on a lot of these programs. So today, what we're going to do is we're going to briefly describe, let me get to the right slide, briefly describe how research on the impact of the arts to health and well-being in older adults is similar to research on lifestyle and health practices such as exercise. We're going to describe the overall process of translation of research to practice and the role of cost in successful translation of arts programs into evidence-based programs. We'll also identify key issues and barriers in determining cost effectiveness, and public health impact, as well as replicating evidence-based practices and programs. We'll define cost and cost effectiveness in the context of public health impact, and finally provide strategies for soliciting and identifying the most promising models to determine the greatest impact of participation in the arts among older adults. When we're working with a field that doesn't have a breadth of research or a framework in which to answer cost and cost effectiveness, we might want to borrow from another field that does, such as physical activity. There's quite a wealth of research that exists in relation to physical activity. And one of the reasons we may choose physical activity as a framework for these questions is because unlike programs like nutrition where we all eat, so it's beneficial to understand nutrition. We don't all participate in physical activity programs. We don't all participate in arts programs. So we're going to borrow some of the questions from that area and apply them to arts and aging. So one question we're going to address is, what are the types and levels of physical activity among diverse older populations? So we're going to take that question, apply it to the arts field. And this question is really epidemiological in nature. We want to understand the surveillance data. We want to understand the psychosocial factors, demographic factors, things of that nature. We want to know who is and who is not engaged in these programs. And we want to understand the scope, and not just the scope of participants, but also the scope of arts programming. What are we talking about here? Question 2, what are the health benefits of physical activity in older adults and the consequences of sedentary behavior in older adults? We can easily translate this to the arts world as well. We need to understand the impact of the arts programs. Without the evidence of benefits, we don't have a lot of motivation to move forward. We also are going to talk about the factors that influence participation in regular physical activity, instead in this case, arts activities. And this identifies correlations of participation, such as the factors that are related to initiation of participation as well as the maintenance of participating in these programs. And finally, can we develop successful interventions and policies to promote physical activity, in this case again, arts programs, in older adults? And this question establishes the criteria necessary for the efficacy and the effectiveness of these programs, which leads to best practices. So let's take each one of these questions and briefly apply it to the arts and aging area. So taking the first question, what are the types and levels of physical activity among older adult populations? How do we define or operationalize arts? Are we talking about arts and crafts? Are we talking about art therapies? Are we talking about community-based programs? Community-based programs should actually be at that list, on the list as well. Those three we really need to understand. Are we talking about all of them? Are we talking about one specifically, 2 out of the 3, etc.? Are we talking about performing arts, creative arts, abstract conceptual arts? Are we talking about participatory arts? That concept has been used often this morning, where are we actually doing the painting, or are we observing and trying to interpret a painting? So we need to have clarity on what we're talking about. Excuse me. We also need to understand the intensity of these programs. Researchers tend to be really good at reporting the research methods, for example, how long observations occurred, or how much time elapsed between measurements, or how long a testing session lasted. But sometimes we're less conscientious about reporting the duration of the arts participation. For example, there's little evidence on the dosage, so how long the programs lasted. And we need to understand that. If we apply that back to physical activity, we kind of have a general understanding that 30 minutes for 5 days a week is the key to receiving some benefits. But we don't understand exactly how much and for how long it takes when it comes to these arts programs. And here is an example of some of the research that exists in this area. We're borrowing this from a review that myself and my colleagues conducted. What we need to know is how many days a week, for how many weeks, for how long. And based on the majority of the studies that were included in our review, we have a lot more questions here than we do answers. So we need to also report on these factors. So what are the benefits? We have to understand the benefits of these programs before we can really get to understanding cost and cost effectiveness. We have, and this is not exhaustive as of today, but this is generally where we see some benefits. We see benefits for general health, decrease in medication use, decrease in falls, better cognition, improved balance, decrease in hostility, anxiety, depression, increased sense of mastery, increased well-being. We need more organization and structure around these benefits. We need to be able to classify them into broader domains, such as pathology, risk factors, impairment, quality of life, etc. A priority is to conduct enough research that enables compelling consensus statements about the benefits of participating in arts programs. The evidence is not yet conclusive, but we certainly do have enough evidence that points in the direction of the positive outcomes for people participating in the arts programs. What factors influence participation in regular physical activity among older adults? Again, easily translatable to the arts program. We want to look at things like past experience. While we can't manipulate past experience, we know that future behavior or the potential for behavior is based on one's past experiences. We need to understand the perception of the activity, as well as just a whole realm of things that motivate people to not only participate, but to maintain participation. Things like self-efficacy, perceived barriers, availability, accessibility, resources on several levels. And we want to be able to understand the psychosocial factors, demographic factors, as well as the program-related factors. And activity fit is also something else that's important as it relates to cost. An activity needs to have the appropriate fit, and that really speaks to maintaining the program participation. So if a program is too challenging and the individual skill level is too low, then there's going to be frustration that's fostered from the program, and there might be some dropout. So we need to understand exactly how we can frame these programs, what resources are needed in order to help individuals maintain participation in these programs. And can we develop successful interventions and policies to promote arts programming in older adult population? And if so, what are the criteria on which to evaluate their success? First, we need to establish the efficacy and the effectiveness of these programs before we can translate the research for broader dissemination. Translation of research to community-based programs is premature in this field at the moment, but given the considerable gaps in the research and, the considerable benefits that we all have experienced in the research, we have potential to move forward. But we cannot answer this question as of yet until we really hone in on answering the first three questions. And before I turn it over to Tom, this is kind of a summary of the questions as it relates to cost. We need to be able to understand the scope, intensity, activity fit, benefits, and how we need to promote these programs to understand motivation and maintain program participation. All these things will go into a cost-benefit analysis, but we don't really have the answers to all these questions yet to be able to provide a true analysis to date. And with that, I'm going to let Tom go ahead and take over. Thank you.
Thank you for the opportunity to explain in 8 minutes what I've been doing in the last 10 years. We'll go ahead and just briefly go over very quickly what those 4 questions were about. Essentially, all research can be subsumed under those 4 questions. If you really look at that, everything we do in our field is one of setting up incidence prevalence, the nature of the antecedents, the proving of its association to a cost outcome, and then looking for the factors contributing to the initiation, maintenance of it, and then bringing it up to scale. Since Emmett did such a great job of setting up the cost analysis, that gives me the opportunity to focus on the real reason why we do what we do for a living. We do these interventions, we do these trials, you devote your career to having it be widespread, to be used for the public good. Well, public health is oriented around that, and another way of evaluating cost is looking at the true value of what we have and the true public health impact of what we've done. Nothing could be any worse than having a meeting like this 5 years from now, having the same conversations again. We should have as an outcome that many of these things are already beginning to be disseminated. So to some degree, I would like this to be one of the objectives that we have. It also shows you the futility of trying to operationally define cost at this point, but recognizing you have to pay attention to cost because cost is associated with the next consumer. The next consumer is the older adult himself, the cost and effort engaging in the behavior, and the agencies, the clinics, the communities, and the organizations to adopt your program. Okay, so all of these do fit into this. The health benefits, I don't think we can fully justify the total benefit that is assumed under a single study on any of these intervention programs. We will be underestimating them. So to some degree, it again is futility. I assume if I just hit this, I'll go to the next one. Perfect. As you all know, really the arts programs, like many other activities, are in a broader ecological perspective. Much of the intervention research that you've seen here is oriented towards the individual in a controlled or semi-controlled situation. And we recognize, and everyone in this room recognizes, that the interpersonal institution and the larger community has a function as well as a setting in which these things occur, and understanding these ecological factors contributes to the degree to which we can begin to estimate true cost. Unfortunately, what happens is that many of these programs never see the light of day. And unfortunately, some of these are seen, and we really shouldn't have seen them. Just say no, Project DARE. We have a whole litany of these. The other thing is, when the Noises have their program and talk about the need for a professional orienting the participants on this, to what degree can this program ever be passed on to a group of non-professionals who could accomplish the same thing? So we're looking at fidelity, treatment fidelity, and the degree to which this thing could be largely disseminated in places that you could possibly attend to, you couldn't attend to. So I'm really interested in seeing if we have something here that has a larger public health impact. Okay, some of it I think it does, and some of it, rightly so, will always be a therapeutic strategy rather than one in which it's a public health strategy. Okay, and the lessons learned from these practitioners out there who will be delivering these programs should be embedded in the way we think right now. For instance, every program has what's called the delivery mechanism, and every program has a therapeutic element. We've concentrated on the therapeutic element, but Cohen has told you that the psychosocial factors that are associated with the behavior itself is one of the therapeutic elements, where we used to disassociate that when we do typical kinds of research. So we have to say, is that part of the cost, or is that part of the way of just doing business? And if so, is that mutable and left up to the practitioner out in the community, or is that one of those essential elements to your program that has to be embedded in the program and never touched? These are important discussion points in order for us to move on this. Okay, so despite these health benefits, progress is very slow. Alameda County population studies demonstrated in the early 80s that there are health benefits of lifestyle. Everyone knows this now. How come we still don't have sufficient number of programs out there for older adults? Are we going to wait another 30 years for these programs to be out there? Obviously, you see I have a thought piece rather than data, but I can supply data for this. So what do we have here that I think is worth emulating? I do think that we can identify a therapeutic element, and I don't propose that we dissect it. Take it for what it's worth. If a program has multifaceted elements to it, that's the reality of the world. That's the reality of how it's going to be delivered. We don't have to isolate that. I love your strategy of having multiple control groups where we begin to look at the relative impact of these various strategies. Many of these are oriented towards older adults as well as those with moderate and significant health conditions. What are we really saying when we have a program for a person with significant cognitive impairment, modest cognitive impairment, or cognitively intact? Are we saying that you can wait until you're cognitively impaired before you have to join this arts program? Because it is reversible. So we have to watch out how we tailor these programs and the messages we give to these. We have to document this impact to meaningful health outcomes. A meaningful health outcome to a researcher is an MMSE. That is not the case to the consumer, the older adult. And the cost effectiveness of the program is a critical element for the agency director, more so than you would expect. So regardless of the nature of the type of research you're doing now, you need to build in some of these components so the next level of dissemination and diffusion is more readily acceptable, more readily to be disseminated, more readily not to sit on the shelf. Okay. Now, where we are with this is we have evidence-based wellness and health promotions that are both comprehensive and multifaceted already out there. We can use those as models. We can use those as a strategy for thinking about that. More importantly, we can use them as strategies for embedding them in already existing infrastructures, whether it be the Aging Service Network or other key stakeholders out in the community who would have a vested interest in the health and well-being of older adults where these programs could exist. We don't have to reinvent the wheel for this. Okay, now how does your program get out there? There was a discussion earlier today about evidence-based reviews. Not every set of literature on a topic area gets reviewed. There is a greater probability of doing that when you have certain characteristics. So if you want your program to be one of those evidence-based reviewed programs, it goes beyond efficacy and effectiveness. There's some other characteristics. Here are 6 examples of some that have made the grade. These are administration on aging, administration community living, that have considerable merit to where they get funded under Title III monies and they are embedded in the community. There's no reason why the arts program could be the next bullet, okay? Okay, you do need to first establish efficacy and effectiveness. So it's apparent that we do have some work to do here. The essential elements have to be clearly defined. That is, you have to say to everyone who takes your program and takes off with it, do not touch this. This is the essential element of the program. If you want to play with the fringe on these things, these are things that you can touch. So differentiate between those two. You need to incorporate the priorities and the realities of the community and the situation under which they occur. And I do think that you need to pay close attention to cultural, ethnic, and other factors that are associated with the nature of the preferences for these kinds of programs. Now, documenting cost and cost effectiveness is very tricky, but you have to try and go ahead and do that to some degree ahead of time, because the very people who will adopt it, the agency directors, will say, how does this program that you're proposing to me matches with the cost of programs I already have, and to what degree is this one in which I will then substitute for the existing programs I have? Okay, and then if you do that, you also have to have a certain degree of demonstrated flexibility to the whole thing, to where you say, this program is still what we intended to be, even though we've done this, this, and this, tailored to the community needs. Okay. When we look at this, we go, my gosh, how are we going to evaluate that? And let me go to that. We use this model, the REAIM model. The REAIM model is a framework which we have in public health been used to think about the nature of how we have successfully accomplished what we wanted to do, broader dissemination, diffusion of innovative programs. If you look at this, some of these are very familiar. Efficacy and effectiveness has to be established. However, we really evaluate the quality of a program on how many people you've actually reached and the nature of that population. We also look at the degree to which it was adopted the way it was supposed to be adopted and implemented in the settings that make sense. The one that we really fall on our face with is maintenance. The maintenance of the behavior. At some point, you will have a program where a person takes 14 weeks, 22 weeks. You have to hand it off to themselves, or you have to have a booster program later. How long do we have to say you have a program before they are able to maintain this behavior without you? You can't always do it all the time. So we have to have tests for long-term impact on this without the intervention from you continuing. Okay. And also, one other thing about maintenance, it's institutional in level. If you bring it to an area agency on aging, how long do they keep it, or versus they just throw it out after a year or two? Okay, so how do we deal with cost? Greater focus on reach. There is no reason why you can't have different costs for different populations. Low-hanging fruit is very cheap. The homebound elderly cost more, but it's worth it. So do not equate costs across all older adult populations. Understand that these things are value-based, and this is why I talk about value-based. Understand the essential elements. The cost for the essential elements will be the ones that which you can quickly operationally define and say it's at least this. The delivery mechanism will vary in terms of cost and is up to the deliverer of that program. Understand the contextual factors within the environment that will actually affect the cost and cost effectiveness of this, and there's some things that you just can't deal with. Okay, and then most important, look at the long-term sustainability. A critical element to affecting this overall impact is right from the beginning, get other stakeholders engaged in this program. You should have advisory groups and groups that are already doing these kinds of programs to pay attention and incorporate this. You actually should be developing your intervention with dissemination in mind. I heard a number of boutique and very costly kinds of measures here which are appropriate for the scientific world, but we should have outcome measures that are meaningful to the older participants to where they can see their own progress within inside of the intervention. And then the continued development and refinement of the program. Although Cohen and your work could eventually be called the gold standard, gold standards are meant to be toppled. Gold standards are meant to be ones in which you say, now I have something even better. So by all means, we should start with what the best we have and keep on going towards that. And then investigate new modalities. What I'm getting at here, and within the minute or two, I want to wrap up here, we really should think about bilateral associations. What is the nature of the eventual user of these programs and how they think of it, how it can be built into it, so we have a better probability of having these programs brought into a greater public health impact. Understand the notion and the concerns about gold standards. And Larry Green always is a great one-liner. And he has, if we want more evidence-based practices, we need more practice-based evidence. And I don't think that we should go in a single track where we focus totally on the RCTs and controlled trials. I think we should go into community trials right off the bat too, and then have the two meet, rather than take time. Okay, I've mentioned all of this before, so to some degree it's in there, it's in the paper. The only other thing I want to bring up is that we have an unfortunate state in the field where even today there are relatively few generalizable, effective, and sustainable programs. I really don't want this one to be one of them. So it really requires you to start thinking about where you are in the continuum. You do not have to be the person who's the translator. You can be the person who does the RCT, but at least let's talk. Thank you.
Our final speaker is Bill Spector, who is a longtime colleague. When we first started working together, neither of us had gray hair, and is now the senior social scientist at the Center for Delivery, Outcomes, and Markets, CDOM, for those who like acronyms, at the Agency for Healthcare Research and Quality, which has gone through quite a few names since Bill has been there. And he will speak to us kind of summarizing and discussing what we've heard. Bill?
Hello, I'm Bill Spector from ARC. Okay, so I just, so that you'll know what my background is, I'm a long-term care researcher with experience in design, implementation, evaluation, interventions for the elderly, amongst other kinds of topics. I have absolutely no research credentials in art's impact on health. However, based on our earlier discussions, it sounds like I'm doing some of the right things in terms of my own personal life. About 3 times a week, I'm taking lessons in ballroom dancing. I'm an amateur chamber music player and started the clarinet at the age of 7. And thinking about a complex intervention, try music camp for amateur musicians. And I don't know if David remembers this, but at one of our Brown University annual dinner or something, it was, he and I performed the piece together. he sang, played the guitar, I played the clarinet. I think it was a lullaby or something. I don't remember, but so I just wanted to refresh that. It was a nice moment, and I wanted to refresh that background. So I think I have some insights into this, and what I'm not going to really go over these, be a discussant like these, a discussant for papers, but to talk about some of the question about what are the costs and benefits, and what does it depend on, and for whom, and I want to also I think and when we think about interventions, we think about drug interventions, and I think and in the work I do, we think about complex organizational change. And so I wanted to go through an example which I think of as a complex arts intervention, and I thought about it as a group music program. So it could be a chamber music camp or something, or it could be a chorus, but it's a group, it's a team. And I didn't like the acronym. So I went to a group arts program, which would be GAP instead of GIMP. And since we're talking about a team now, it's like, what are the benefits and for whom? And I want to pick up on this. We've heard about cost-benefit analysis for the society, but the costs and benefits don't always go to the same people. And so let's put this in the context, and what are our goals if we're trying to implement the program that's actually going to get implemented, then maybe we have to think about the costs and benefits associated with an implemented program. Because and then also, I know the meeting's about health, but wouldn't it be nice if we could show that arts programs affect healthcare costs, or sick days, or maybe insurance companies will be interested in this, and so we could take this further. So thinking about what our goals are, and we'll see. Thinking about who the players are and who we're talking to. So just making the point, the program has no benefits if nobody offers it and nobody participates, and then ask this other question. We heard before that we were talking about arts programs are like exercise. And I was thinking about this, and then I said, well, maybe it's more like baseball. So again, it'll depend. So I'm going to try to answer that question, or at least think about it. And maybe I've set this up because we're talking now about an arts program as a team, but I'm not going to worry about it. Okay, now who are the players? In the world that we're thinking about, the cost-benefit analysis is good for the funders, for the foundations, thinking about what do we do for society. But the people that are going to do most of these programs, we're talking assisted living facilities, nursing homes, adult daycare potentially, and then there are all these programs that are out there aimed at us amateur musicians and artists and choral singers and et cetera, et cetera. Those are potentially, if those people are doing these programs because they're poor, right? They can't make enough of a living, so they're starting camps so that professionals can teach amateurs. Well, maybe these things should be subsidized because they have benefits for health, et cetera. So it's something to think about. And of course, the participants are the older adults that we're talking about, and depending on what kind of outcomes we're trying to study, it could get insurance companies interested, it could get corporate programs interested, and certainly exercise has gotten to that level. We're certainly not there yet. So the context that I want to just to remind us about is that a lot of these organizations that we'd want to try to implement this is they're for-profit and they're non-profit, but not all the costs, the benefits to society they would get those benefits. So it's not internalized by them, so that has real implications for why things potentially aren't getting done. A nursing home, I did some theoretical work a while back based on how things are being funded and reimbursed. They're really interested from the revenue side about how many private pay residents that they can attract to their place. Now, will a good arts program do that? It might. But that's what they're interested in. That's what you have to try to sell this for them. And so that's some of what we have to think about. And then the other thing in sort of the market world that we live in, the consumer probably doesn't have a good ability to evaluate a good arts program. I mean, we were having trouble in our discussion earlier. What's the intervention that's going on here? Well, they need to try to figure out what the benefit's going to be for them. And they're also probably making choices about what assisted living facility do I join. And the arts program's only one piece of what they're choosing. So we just have to understand where we can make an impact. Okay. And also, I want to talk about thinking about an intervention, not like the clinical trial and it's just sort of hovering over there, but something that's actually disseminated, implemented, and what's it going to take? Because the question is, what's the intervention and what's our goal? And if it's an implemented program, there may be things we have to package this intervention with. For example, the educational program necessary to let the consumers know the benefits, or at least the theory behind the benefits of these arts programs, is something that the assisted living facility is not going to do because they don't get the benefits for all that. So there's some public gain arguments for why a foundation or somebody might want to do it once and disseminate the educational program. And we also have to, in long-term care, we also have to realize everybody's really busy. Nobody has enough money to do what they're supposed to do. So if you wanted them to do something extra, then you have to figure out, and you have to train them to do it, then you have to figure out, and that has to be part of the strategy of thinking about this, doing this. Okay, so I want to go through this GAP group music performance, group arts program, or whatever I'm calling it. So the reason I do this is because and we talked about it earlier. I was thinking, was I coming up with good thoughts about this, since I don't know the field real well. But I did cram a little bit on the brain plasticity research, so that helped me a lot in terms of the theory about thinking about this. And so I want to just go through an exercise. So what I mean by a complex intervention is that there's a team of players, that people have different roles, they have to interact with each other, they all have different challenges in relationship to the overall goal. And we think that this could be nursing home quality improvement team or something, but it's now our chamber music group. And I think, and that's in contrast to something like a simple intervention, and the first thing I could think of was maybe singing in the shower. There's no team involved, and So what is this group arts project? Well, I mean, when people talked about the choral group, I'm thinking, is that what's the intervention? So I started to think through this again. And so you have a chamber music group of people that are trying to do something. We haven't decided what we're trying to do yet, so we still don't know what the intervention is. But there's basically three components that I could think of. There are the rehearsals. There's the practice that goes on so that you don't embarrass yourself in the next rehearsal. And then there's the performance. And based on my reading of the brain plasticity, there's the outcomes for each of these pieces, cognitive and physical, etc., are going to be different. And so I just briefly thinking about this. In the rehearsals, I mean, we're now talking about interactions. We're not what. I might play the clarinet, so I've now learned that both hands are involved, both sides of the brain. There's lung effects. It's not just like the piano. It's not the violin. I mean, so there, benefits to me might be different than other people as well. And we have to interact. We're talking about making music together. This is decision making, and it's learning about making pitch match, it's rhythm going together, it's orientation, concentration. I mean, there are a huge number of possible benefits when we're talking about this. We just assume that you have control over your instrument at this point. But in an amateur chamber music camp, I'll tell you, people have different levels of control over their instrument. And then there's practice. And there were some studies that I saw on the brain plasticity thing that professional musicians that practice more have different kind of brains than those that don't. And retirement to me means that, and I was glad to hear that I was on the average, that I practice about a half hour a day. Professionals practice about 2 hours a day. That was, when I think about retirement, I think I'll go from half hour a day to about 2 hours a day. And I'll tell you, that's a huge difference in terms of how you get into the music and what you can learn. And also, the other thing that's worth thinking about, and it becomes this issue about the coach. I mean, in the chorus or in the theater example we had, the effect might be the coach, right? And that was talked about. But there, in the chamber music program, we have coaches. But at other times, if you're doing just chamber music activities, you might not have a coach. And the question is, are you just doing it to have fun, or are you doing it to get better? I mean, I believe over the years I've gotten better as a musician, and I bet, but I don't know as a researcher, the fact that I've gotten better probably means that the overall impact on my life expectancy, etc., or not dying from Alzheimer's like my father did, may be different. And that gets down to this issue. And then practicing is an isolating task. And, I mean, it's not interactive in any way. So there are, again, all these. So we really need to think about, my main point here is these interventions, it's not just chamber music, right? The issue becomes, how much practicing did you do? That's part of what the effect is. And again, I'm going to pick up on David's comment about there's no side effects, and we've heard this twice. I mean, people get injured. I mean, there's a whole industry out there of people that work with professional musicians, but amateur musicians will get injury. Your shoulders, your elbows, your hands, the inside of your mouth from the reed and the mouthpiece. I mean, there are a lot of injuries that happen. So there's some risk involved. There is some injury risk if you're getting involved in this. And one of the when we think about the intervention, now, is there a performance? Because then that's a whole different experience than a rehearsal. I mean, there's a whole sense of risk involved, stress, and what if the performance is a dud? What if all of a sudden, and this happens to amateurs, you have to stop? It just fell apart, or something like that. I would bet that the stress from that might counteract all the benefits that you've gotten from cognitively from what you're doing. So these are things that are worth thinking about. And coaches have techniques. I mean, you take lessons, and I had lessons for a while, and I didn't learn as much as I learned from somebody else. So if you don't do something about what the coach is doing and standardize that, then this is not a replicable intervention. Or you have to think about potentially. And if you're trying to, it's not like this coach is going to go to every assisted living facility and do your intervention. So if that's not the case, then maybe you need to train the trainer manual, and you need to do that. And if facility might prefer to have somebody come in and just take the whole package, or they might prefer to have their own recreation staff do it if what you're trying to do is possible. So then the effects depend on the cognitive and physical challenges for the individual. This is this intensity issue. We heard that we need to document the intensity of the intervention, but it's not just how many hours you did this thing. It's not how many hours you practiced. I mean, there's some, I don't know, musical pedagogy literature that'll tell you it's how you practice that matters. It's not that you just play the same easy stuff over and over again. You need to focus on the hard stuff. And I think if you focus on the hard stuff, that's probably where you're getting your cognitive benefits for the future. So the trick in this, I think, is trying to figure out what the intensity, and that's like exercise. Because we had an experience where we had an NIH-funded project that we were replicating at ARC. And the study had effects. And we replicated in assisted living facilities. And we didn't get an effect. And part of the problem was, when we look back at it, that in the field, people were not that careful about replicating the intensity. It's easy. You want to get people in the program, and people are in there to have fun and enjoy the social activity. But if you wanted to get a health effect, you have to have the intensity up to where it's supposed to be, but not too far, right? Because then you hurt people. And again, it's I think the same thing. Chamber music camp can be dangerous. You're used to amateurs, you're used to practicing half hour a day. You go to chamber music camp, 6 hours a day you're doing this stuff. And if you're a cellist, you're carrying the cello on your back to the rehearsal. And if you're in your 80s, you probably are trying to figure out, do I have my music? Where am I scheduled to go to this room or that room? And that's part of the intervention, it seems to me. Did I lock my door in the dorm? You know? So again, it's a complex thing, but there are a lot of things to think about. Otherwise, you're going to have an intervention you think you've replicated, but you haven't, or you haven't replicated what's important, and then it's not an intervention. And so that's important. So that, again, this came up before. I was happy that a lot of these things have come up. And then again, I go to chamber music camp. I mean, I do some of these things. I'm motivated because, treadmill is boring, but ballroom dancing isn't. And, chamber music's just something I've been doing for a long time. And I try to get better, and I think I get better. And hopefully this has an impact. So just let me touch on a few of these issues. I think we need an educational programs are probably part of the package. So the cost of making the educational program for the consumer, for the provider, is probably part of the cost that you want to incur for the implemented intervention. The business case, I think, is another one that again, a cost. You need to really spell out the eligibility criteria. You need to, for the coaches, if there are any, for the staff, and the time. That it's not just time, but of course you need to do all that. And then it may be that if you want to make it easy for people, there needs to be, maybe there's a manual that helps the recreation department to learn how to integrate in arts programs into their program, where they've done up to this point is, turn on the radio and that kind of thing. And let me jump to this one. And again, the benefits. In research analysis, we need to worry about, we can do interaction terms to some extent, the power of test is there. And we're thinking about a team. Ballroom dancing is a team. But the man orchestrates however women feel about this. The woman follows. That's the rules of the game. And I was told, therefore, I think the man gets different benefits than the woman in this. Because orchestrating, executive functioning, etc., is part of something. But then I was told, and I think this is some famous quote, women dance backwards on high heels, so that has a separate impact. And then what's accomplished? Because there's a group in Rockville, Maryland. Every Friday night they meet, chamber music, they sight read. And we've heard sight reading is different than the impact of sight reading is different than learning a new piece and trying to work on it. And then if the piece is challenging for somebody and not challenging for somebody else, different impacts. And I'm running out of time. Oh, and then one other piece that might be important, and which we've done in some of our own interventions, is to build in a facilitator. So instead of just handing somebody a training manual, you have somebody that gets trained from the organization that teaches them how to integrate the arts program into their organization, works with them over the phone or whatever. So a facilitator may be a cost as well. So my conclusion is I think what we're talking about is more like baseball than it is like that is an individual exercise program. And I don't know who gets the benefits. Is it the worst players or the best players? I don't know. But the issue is I think that we really need to think about is what's the intensity of the intervention and how do we do it? And if we're talking about an implementation, don't think of just as an intervention, but think about a toolkit.
We have time for maybe one or two questions. Yes, in the back.
Andrea Sherman, and I'm with the National Center for Creative Aging and with the Washington, D.C. Geriatric Education Center. And we are in the process of developing a toolkit for healthcare providers using the humanities and the arts to teach core competencies in aging. And I think it's really important to include in the conversation about cost-benefit and cost-benefit analysis the healthcare providers and the values of arts and humanities for them as well. I don't think we should leave them out because they've been kind of a subtext of some of the conversation. Also, for family caregivers, there's an enormous benefit of the arts and humanities to them as well. So I'd like to include caregiving in the conversation.
Thank you. Very good. Well, I'm going to take back my original introduction where I said that this is something that doesn't have adverse events, adverse side effects. I'm still wondering about that question somebody raised, is poetry ever killed anybody? So if somebody can come up with an answer to that, I'm still dwelling on that. We're going to give you guys about a 7-minute break. Meet back here at 2:30. Thank you so much.
So, David, do you know the poem by Dorothy Parker?